Hello and welcome to our conversation on the future of cancer care. I'm Kim Holden, and today we are highlighting groundbreaking advances in treating blood cancers, leukemia, lymphoma, and other hematologic malignancies, and what they mean for patients everywhere. We are joined by three leading hematology oncologists from Our Lady of the Lake Cancer Institute, Dr. Hana Safah, Dr. Nakhle Saba, and Dr. Sequeira. Thank you so much for being here today. We really appreciate it. To kick off this discussion, we're going to start with each of you briefly sharing what your work in treating blood cancers involves, and we'll just go down the line here.
Well, thank you. Thank you for that question, and I'm happy to be here today. So, at the lake, what we're doing at this point is truly focusing on the way we should be treating or treatment of hematologic malignancy should be. So we're trying to departmentalize the treatment by just putting the expertise for that disease in that department or that for that disease area. For instance, I'll give you an example. I take care of patients with multiple myeloma and myeloproliferative neoplasm like myelofibrosis. And I focus on these two diseases mainly, take care of the disease from diagnosis to treatment, whether it's standard treatment, and even provide my patients with options regarding clinical trials that can be related to those diseases. And I'm going to leave the rest to my colleagues to speak about their disease area.
Dr. Sabah?
I totally agree, and I second what Hana said about the subspecialty in cancer. It's becoming more and more difficult to lump all cancers under one title, which is malignancy. You have to subspecialize in order to deliver the best care to your patients, and this is what we're doing. We do not only subspecialize in blood cancer, but within the blood cancer, we're subspecializing. So Dr. Safa mentioned myeloma and MPNs. For instance, I see the lymphoma and lymphoid leukemias. And I'm going to pass it on to Dr. Sequeira to talk about his specialty.
Thank you for having us. And just to echo what they said, I think the fact that we're so specialized allows us to give care at the highest level. So we're not only choosing the treatment very particularly in small things for our patients to get the best outcomes, but we make sure we give a holistic approach to our patients. In my case, I specialize in leukemia, especially acute myeloid leukemia and myelodysplastic disorders. Very passionate about clinical trials, so this is our hope with our patients, open, pertinent clinical trials for them.
Okay, and we're going to talk a little bit about clinical trials coming up, but let's go to the big picture for a moment, the modern approach to blood cancer, if you will. So for a patient who's diagnosed with hematologic malignancy, what does the overall treatment landscape look like, and what are the main pillars of care? Dr. Sabah, let's start with you.
Sure. The three main pillars, in my opinion, are number one, subspecialty, and we just talked about that. Number two, a robust clinical trial research program, what Dr. Sequeira touched base on, and then access to care. In summary, with point one, it's again, a one-man show is not the way to go in cancer. You have to be subspecialized. It's becoming humanly impossible to keep up with all the advances and new treatment in cancer, and even the subtypes of the cancer itself. For instance, in lymphoma and lymphoid leukemia, there is more than 70 subtypes, and that's what I do. Just imagine, let alone the most common malignancies in the solid tumor department. Number two, a robust clinical trial program will ensure that you bring the latest and greatest and the cutting-edge technologies and treatments to your patient's population. And those are the treatments that we see that they have a bright future. They are not approved by the FDA. They are in the clinical trial setting, and those are extra options for our patients. Sometimes we believe that they're more even promising, depending on what we have in terms of early data. And number three, access to care. And that's a big problem in the South, particularly in Louisiana, with our Medicaid population, for example, and our access to CAR-T that we're going to talk about, and the ability of institutions, big institutions like the Lake, to accommodate these technologies and these big treatments and deliver it to everyone who can or who needs it within our patient population.
And Dr. Safah, what do you have to say about the big picture of these cancer treatments and the main pillars?
I think, to me, just to add to what Dr. Saba said, also the timely diagnosis. We have when these patients present with, especially with heme malignancy, you don't have enough time. You don't have the time to just wait on a diagnosis to come, especially if it's a leukemia or a very bad myeloma or a very aggressive lymphoma. So what we're creating in the lake is the ability to have the diagnosis made within, I would say, a few days, and that's something you don't see in in community hospitals as such or practices. So that's very important for patients with heme malignancy. We're also starting to bring in what we call precision medicine, where we treat the patient based on very personalized genetic abnormalities that we can detect. So that's why diagnosis and making the right diagnosis early on is going to really affect the outcome of the patient. So not only the treatment, but being able to make the diagnosis in timely manner and also bring in all the details that can affect the outcome. That's very important, and that's what we're bringing to the lake too. The last one is we look at survivorship of the patient. So we're not gonna only focus on treatment itself and diagnose, but also what can make the patient do better, and everything that is needed within that supportive care for better survival is going to be added to the care. So that's another thing that we have learned, that it's not only our treatment with chemotherapy or whatever that allows the patient to do very well. It's everything, whether it's nutritional, social services, everything, and that's all going to be provided at the lake as such.
Okay, Dr. Sequeira?
I would add that it's important to talk about the context where we are right now, where we were 10, 15 years ago. Specifically, in my type of cancers, 15 years ago, patients didn't have that many options. And it's been an explosion of options for those patients. And the right conjunction of clinical trials, access, and the three pillars at the same time, at the same place, are the things that make the difference for patients. And that combining with a holistic approach, like Dr. Safah said, that is our goal. It's making the patient feel not like a diagnosis, but like a person. And making sure that process is something that will, be easier every day that we are with them.
And within that landscape, one of the most exciting frontiers is cellular therapy. Can you explain what that is, and really how is that changing what's possible for patients right now?
Well, that's a great question. Cellular therapy encompasses a group of procedures. It can go for something like bispecifics, something that harvests your own immune system to kill the cancer. CAR T, which is a little bit more sophisticated version of bispecifics. They have to go to a lab. There's a process for that. And the last one is transplants, which can be either autologous transplants or allogeneic transplants. Over the years, not only we have more products, we have learned how to deliver them safer to older population and achieving better results.
And you mentioned the CAR T cell therapy. That's a term we're hearing a lot more now. So does anybody want to chime in on what exactly does that do, and how has this been such a game changer for certain patients?
I can take that since I'm leading that effort at the lake. Excuse me. So let me start by the fact that cancer happen in humans. Sometimes we don't know about them because our body take care of them. In our body, I mean our immune system. But sometimes the immune system would lose the ability to see or detect the cancer, and this is when the cancer, in terms of blood cancer, can flourish and then the patient is diagnosed. So what we're doing in terms of CAR T, we're taking part of this immune system, which is the T cell, it's part of our immune system that is responsible of fighting the cancer. We take it out of the patient's body, and then we re-engineer these cells in order to be able to fight the cancer back. In other words, and in layman language, we weaponize these cells in a way, and then we expand them in the lab. We make a small army out of them, and then we give them back to the patient. So when they go back in the body of the patient, with their body, they can actually now see the cancer and then attack it, and then expand and make more copies, and then attack more, and then kill it. This treatment has been out for several years now. We are the first in Baton Rouge to bring it to the city. We also are investing in the clinical trials with the next generation CARs, and those are more sophisticated. For example, we bring them from a healthy donor, re-engineer them, give them to the patients. Those are in form of a clinical trial. We were the first to bring them to the state of Louisiana, and we were the first to treat the first patients here at the lake. We're very excited about that. Now, the CAR-T does not limit its potential to the blood cancer only, but it goes beyond to solid tumors as well, and to other non-cancerous conditions such as autoimmune diseases, severe lupus, myositis, etc. We're also bringing those trials, particularly in the field of autoimmune disorders, to the lake in the setting of clinical trials.
Okay. So, like you said, beyond cancer, and the success rate so far?
Depend on the type of disease. The most aggressive lymphoma in the United States, and the most common aggressive lymphoma is diffuse large B-cell lymphoma, most common lymphoma in adults. If it fails the frontline treatment with chemotherapy alone, we talk about cure even when the cancer comes back in the second line, whether with autologous transplant or with CAR-T. With CAR-T, we're talking about 40-ish% cure rate. If we talk about follicular lymphoma, which is less aggressive, which is the most common, less aggressive lymphoma in the United States, we're seeing long-term disease control. Even some experts are talking about cure in this lymphoma. We never talked about it, and we're talking in the 60-70% range. In myeloma, there was a Wall Street Journal, New York Times article actually a few weeks ago that talks about cure in multiple myeloma. By definition, I'm going to let Hana talk about that. I'm sorry, I'm not stealing your thunder here, but by definition, myeloma is an incurable disease. Now, seeing that is really phenomenal. So it is transforming the natural history of these cancers. I'm so excited about it. We have to have it.
We're not going to let him steal your thunder, so go ahead.
Yeah, so it's interesting that when we speak about cellular therapy, it's this knowledge that we have gained through the years about how the immune system takes care of cancer. And we learned about the immune system, the role of the immune system from allogeneic stem cell transplant, when we learned that it's not the high-dose chemotherapy that's killing the tumor, it's the cells that we got from the healthy donor that are taking care of the disease at the end. And then we said, why don't we use the cells of the patient and re-engineer them to come up with the CAR-T? So the concept of using the immune system is really interesting by itself, where you can use it in patients who have failed the chemotherapy or where they have become refractory to chemotherapy that we used to use in the past. In myeloma, again, as Dr. Saba has just mentioned, or Nakhle, is that we're looking at the role of CAR-T in patients who have failed stem cell transplant, because stem cell transplant in multiple myeloma is considered the standard part of the induction therapy. So it's a standard therapy of frontline. When these patients fail multiple lines of therapy, CAR-T is giving them the option of going into remission and complete remission and prolonged complete remission. So now they're speaking of, could CAR-T bring cure to multiple myeloma if used at an earlier line? And that's something that is being studied for now. But I cannot tell my patients right now that CAR-T is going to be the treatment of choice. I'm hoping that within 5 to 10 years, we'll have some more data.
And what are the risks involved? Powerful therapy, so the side effects, risks?
Yeah, I mean, there are risks with every treatment, right? And that's why we need to be careful when we usually approach our patients with the recommendations. We always evaluate efficacy versus safety at that point, and we always say we base our decision based on evidence-based, right? A study, the trial, what did they show? But with CAR-T, when we speak of CAR-T, there is something called cytokine release syndrome, where and that's usually can happen within few hours, rarely within few days, and can happen later, but very, very rare. But it's usually fever, hypotension, and that's we follow our patients closely for that. That side effect is becoming less and less. We're learning how to manage it. We're even learning how to prevent it, as Dr. Saba can speak of. We're moving away from admitting patients for CAR-T, for these cell therapy infusions from being done as inpatient to being done as an outpatient, because with time we have learned how to take care of them, and not only that, how to prevent them. So honestly, I feel comfortable now saying that we can do these kind of infusions in the infusion center the way we used to give chemotherapy in the infusion center. So yes, so it's cytokine release. There are some neurologic complications that can happen, but also very rare, and we'll educate our patients and the caregiver on how to follow those side effects. The last thing I would say, there have been some observation that will be there is increase in the secondary malignancies with CAR T, but that's something also that we're waiting for more data to come out on.
Okay, all right. Dr. Sequeira, with more of these powerful therapies now available, what's the different first conversation that you're now having with patients?
That is a good question. And just to come back to a few questions back, we talked about targeted therapies and how the context changed with targeted therapies. If we were have this conversation 15 years ago, we will have one or two options for those patients. But now we not only have more options, but we can personalize it to that patient. Now the conversation, we try to keep it always with a hopeful tone, especially with the newer options. And not only have we learned that these targeted therapies can be more effective, but we can deliver on a safer fashion for these patients. Now, the clinical trials, what we'll explore is how we can mix and match what is the right combination of what dose to give the best response to those patients. And nowadays, with the classification, so let's say we get a new patient with AML, the first thing we will do is we will diagnose that patient and we'll get the genetic footprint. With that genetic footprint, we will classify that patient in a risk. Are you in the better risk, in the middle risk, and the lower risk? When patients are in the middle and the lower risk, our goal is to take that patient to allogeneic stem cell transplant, one way or the other. And this conversation has been easier with the newer strategies that we have right now and the treatments that are able to achieve a better complete remission for these patients.
Okay. And Dr. Safah, you, as we mentioned, helped build the CAR T program here. What was the biggest challenge in making this highly available to the community? Because we talked about accessibility earlier. What's the biggest challenge there?
Set aside the institutional commitment, which was a big thing to have, which we had here at the Lake. In my prior career, we tried to bring it to Louisiana, and we failed because of mostly the commitment of our partner and the institutions. We need to have the other services available, the training, the financial part of it, the infrastructure to support such therapy, especially if, like Dr. Safah said, we're planning to do outpatient. We're able to get that ball rolling in terms of infrastructure, institutional support in really no time. However, the biggest challenge that I see, especially in the South and Louisiana, Mississippi, Alabama mostly, is access to care. Access to care would be summarized in two major two problems. Number one is the ability of the covering entity, such as insurance, to cover that, and we're really doing a lot of work with legislation on this. And then the second, the socioeconomic status of the patients, particularly those who do not live close to the center. So these are the two major problems in terms of accessibility to the treatment. We have it. We have it here at the Lake. Now, some patients might not be able to do it because they might not be able to travel. We're working on that. We're having we're trying to get the housing, the financial support for them, and then also working with the insurance counterpart to make sure that this is also covered, in terms of anti-cancer treatment like anything else. So there's a lot of work to be done, and we're working closely with other partners to make that happen.
Have insurance companies pushed back on that a lot?
Yes, and the particular problem is the Medicaid population. That's somewhat challenging. Some private insurances also would prefer some centers out of state. We're trying to keep everybody near home. We are delivering the same care, the best care. We are all equipped. We are certified by the pharma company who deliver this drug to give that. We're seeking also what we call FACT certification or accreditation in order to be a dedicated center, and that's happening as we speak. But yes, we do have pushbacks from insurances most of the time, actually, fortunately.
So if I can add to that,
Sure.
is what we're trying to do as a group, as a department for heme malignancy, is how can we improve that access by making pharma open studies at the lake that also can deliver such form of therapy, cellular therapy, on clinical trial basis. And that's going to be beneficial to all, because by doing that, you will ensure that this kind of therapy is going to be available for all, especially the minority population, which usually lacks representation on big trials that are done in other centers far away, because they don't have the ability to go there. But we're going to bring those trials here. This way, we'll make those kind of treatments available for all, and also those trials will include patients that were not included in other trials in the past.
And I think you just answered my next question about why the clinical trials are so important. Dr. Sequeira, do you want to chime in on that?
But I will say, I will just echo the same thing. I think, and I said it before, I think the clinical trials has helped us position where we are right now. The clinical trials is the way to find better cures. The clinical trials is the way to find better response, safer response, and in some cases, the clinical trials will cover some of these costs for the patients, and that will help access for patients. So not only we can give them a newer potential standard of care, but sometimes we can give it with covered cost, and that combination, it's unique.
Yeah, and I'd like to add that we're always talking about the future, but those trials are already set there. I want to make sure that this point is taken. We have trials that are enrolling patients to be treated with CAR T, and we did that already. There is a multiple myeloma CAR T trial coming up very soon. There is an autoimmune diseases also coming up, so that's happening as we speak. But we always, when we talk to the patients, we have the standard of care options, and then we have the clinical trial options. We always make sure that the patients understand that this is totally on a voluntary basis, that they understand that these treatment, we don't know which way they're going. Yes, we do believe that they have a potential, but also this is a standard of care. Think about it as an extra option. Nothing going to change their relationship with us, whether they agree or disagree. This is the basic of clinical trial. They can pull out at any time. They can say no to yes today and no tomorrow. That's totally fine. So they need to understand that this is, an option for them. They can go in or out at any time. And we always chime in with our opinion, because it's not fair to the patient to put all the options on in front of the table and tell them to choose. This is why we're here, to tell them, okay, well, we think this is plan A, this is best for you, but also we can do plan B or plan C. But why plan A is better for you from our standpoint, and why plan B and plan C are number 2 and number 3. Basically, we put all possible options that we think are acceptable on the table, and we grade them by our preference in terms of our expertise.
Okay. Dr. Safah, are the new cell therapies like CAR T replacing those traditional stem cell transplants, or do they actually work together?
I think some people would say, oh yeah, that's what it. No, honestly, no, not yet. I think currently we can be comfortable saying that stem cells still have a role, and that's something that, especially with certain diseases, still there is a role of the high-dose chemotherapy in overcoming the stubborn tumor and supporting that with stem cell transplantation. In fact, when we do stem cell transplantation, we're giving those cells back to the patient so that they can survive the effect of the high-dose chemotherapy needed to kill the tumor itself. Now, when the tumor becomes refractory to chemo altogether, the high-dose chemotherapy is not going to help, and that's where CAR T is going to come in as an option. But so I don't think one is at this point, without more data coming out, is replacing. Now, ask me 15 years from now, I would say maybe we have, especially with multiple myeloma, we might have the data that if we start earlier with CAR T, we don't need to go to stem cell transplantation. But for now, stem cell transplant is here to stay.
Okay, Dr. Safah, your research targets specific pathways in cancer cells. So why is that personalized approach so important across the spectrum of blood cancer treatments?
Sure. The one-size-fits-all strategy is gone in cancer care. And this is why subspecialty is really important. Right now we have an explosion, Dr. Sequeira called it, of novel treatments in cancer in general, including heme malignancy. I barely can keep up with lymphoma. I'm telling you
That's a
that
good thing.
with so many agents. Now the big question is, what is the magic combination of these novel agents, of these targeted therapy? So targeted therapy are either small molecules or antibody that targets vital targets inside these cancer cells and sparing normal cells. So we have so many of those, whether CAR T, whether bispecifics, whether antibody, whether small molecules inhibitors. So what is the magic combination is going to make this, perfect dish in terms of treatment strategy? This is the million-dollar question that we're all trying to answer. And that, coupled with the patient's condition, patient disease, subtype, other medical problem that the patient has, the medication that the patient is taking, and the interaction with these cancer treatments will make the perfect mosaic picture for that particular patient as opposed to the next patient. So one size fits all is gone. It has to be personalized medicine in order to achieve the best results.
Okay, and what does long-term look like? What does life long-term in care look like after advanced treatment like this, Dr. Sequeira?
Well, it depends on the type of cellular therapy that you get. Depending if you get an autologous, allogeneic, or CAR T therapy, the type of surveillance that we will do for these patients differ a little bit. If we talk, for example, about allogeneic stem cell transplant long term, we will have a special clinic called Survivorship Clinic, where providers alongside us will start doing surveillance, taking that the patient doesn't have any complication for the procedure. We're always looking for any interaction of the graft and the patient that can happen at any point. And we want to make sure that people and patients are able to go back to their life as soon as possible. So even after getting these very complicated intensive therapy, the goal is for them to go back to their life at some point. And that's our goal too. So the timeline can be different depending on the patient, the therapy, but the end goal is the same for all of them.
I like to add
Yes,
something just
yes.
to chime in terms of what's going to happen to those patients in the long run. I see two things. Number one is a chemo-free cancer treatment. That's happening. I mean, in chronic lymphocytic leukemia, or CLL, which I specialize in, we don't use chemo anymore. It's still being used in the community in some places, unfortunately, but we have shown that targeted therapy is safer and superior to chemo in multiple clinical trials. So we moved away from chemo completely. Number two, I do see cure in a lot of cancers that we never dreamt that we can cure before. And that's probably are happening. I know Hana is a little on the conservative side. I'm more excited about it. I think that's happening. And whether we can cure the patients from the front line or second line or third line, what is the minimum amount of treatment that we have to do in order to get the patients back on the track with a normal life expectancy? That's what we're trying to do at the time.
And targeted therapy is known to be associated with better quality of life, and that's CML is one of the very good examples. We used to treat CML with chemotherapy, and then Gleva came up, which is a very targeted therapy, and now we're curing patients with CML with chronic myelogenous leukemia with a pill that they take for 3 to 4 years, and if they go into deep remission, we stop it and the patient is cured. So that's a beautiful example of how targeted therapy and what we call precision medicine is going to be very important in taking care of patients with heme malignancy, and that's what we were doing at the Lake. We're starting with the appropriate diagnosis, the accurate diagnosis, so that we can improve the outcome afterwards.
And that pill made the national news at the time. Was, I believe, at the New York Times, Wall Street Journal. A magic bullet for cancer,
Yeah, I mean, I think everyone wants to hear the word
bring
cure.
back that cure.
Absolutely.
CAR T again.
Well, this has been incredibly insightful. To close, I want to ask you one more question, just one final thought. If there's one key message you want patients and their families to take away from this discussion today, what would it be? And Dr. Sequeira, we'll start with you.
Tough question. I think the key message will be we're here to change the statistics. We're here to lead the cutting edge treatment and to be next to them in the most difficult times. We will be here, and we're always going to be available for them, either in the standard or clinical trial fashion for their treatment.
Okay. Dr. Saba?
Don't give up. Seek a second opinion. Seek a subspecialist. In the end, your doctor, whoever he is, he needs the best for you. You will not hurt anybody's feeling, not us, not them. We are on your team.
I say we got you. We got you with this cancer at the lake. That's exactly how I'm seeing the program that is being put in place to take care of those patients. And we got them, and we got the caregivers too, because I think it's a journey, not only for the patient, but for, for their family members and loved ones. And we're building a comprehensive center that will take care of the patient with all their needs. As I said, it's going to be a holistic kind of treatment for those patients.
So glad you mentioned the caregivers.
And I want to say
Yes.
one thing, which is very important. Patients of Louisiana should stay in Louisiana, and there is no need for them to leave Louisiana anymore.
Okay, good to know. We are so grateful for Dr. Safah, Dr. Saba, and Dr. Sequeira sharing their insights, their wisdom, their expertise, and their vision for the future of cancer care. Thank you so much for being here today, and thank you to everyone watching. I'm Kim Holden.